visiting Dr. Wu's center about a month or two ago, and it's amazing what he's done to continue on the Stanford tradition. It's just a very impressive place. Of just he surrounded himself and the rest of the team with just the most intellectual, excited young people. It's really exciting, and it's great to see it's turned into something unique. Next, Bo Yang is going to come tell us about patch enlargement. And when you first see this procedure being done, it's kind of complicated. It seems complicated. But then when you watch Bo do it, he makes it simple. So.
Oh, here. Okay, thank you. Okay. Yeah, Mara told me keep it tight. Okay, I'll stick with 10 minutes, already over. So I think, thanks for the invitation, and congratulations to Dr. David. This operation, I think, is more important to know why we need to do it than how. It's a simple operation. It's much simpler than Ross and David procedure, but how we use this operation to help patients with aortic stenosis patients. So as Dr. David mentioned, the normal annulus is not big. Man here is 23, and the female is 21. That's why most of the trials, all the studies showed the most common use of valve, either 21 or 23. But what is the opening of this valve, right? You have to think about is it comparable to the normal annulus? So the labeling is very deceiving. You see the ID is in the diameter, right? It's not the opening. It's in the stent. It's the metal part you cannot see there. A real valve opening, like size 25. This is 24. You can never pass 24. You can only barely pass a 21 millimeter. This is before you put it in. You put it in, pelagic tissue protruding to the blood path. It's even smaller with size everyone. So the 29 valve has in opening is 23. A 23 valve has opening 16 millimeter, which means every man here need AVR. You need a 29 valve has opening, match your native and original annulus. If you put 23 in, it's 16 millimeter. What does that mean? Oh, this is not just me measured. This is from FDA. FDA also 4 companies measure all the valves. They are real opening. Look at the Magna E is 29, and up 23. Very consistent by 4 companies. And 23 valve, 17. Average valve, 27, 21. It's about 5 to 7 millimeters smaller. This is the difference. This is why the bioprosthetic or mechanical valve, the opening is so small when you enlarge the root. So now, if they requires that all the company put the EOD, which is effective orifice diameter here, like 29 valve, 24, 27 valve, 21. This is real. Next time you put a 23 valve in, put a 21 valve in, measure how big it is. It's really small. So if patient, any man here come to us as AVR with annulus 23, original area is 4.15. Then we put 23 valve in, size 23 valve, 16 millimeter. What did we do to this patient? Basically, we reduce the area by half. We put the valve into a patient without enlarge it, normal annulus size 19 to 25. Drop a valve in without enlarge it. We immediately downsize the valve size by half. Immediately PPM. This is recognized in 1978 by Dr. Watahula. I forgot the name, but in circulation. So I calculated the annulus from 19 to 25 normal annulus size, the areas 3 to 9. And this is FDA data for all the valves. You put it in without the enlarged, the area dropped from 1 to 2.5. Basically, we decrease the area by 50, 60%. This is how bad it is. We do not do enlargement, how bad we did to the patient. What happened to the long-term survival? We just heard Joe talk about the Ross procedure. Ismail always said Ross procedure has the best outcome and match the general population. This is our unpublished data. So patient with annular size 23 in men, right, average, put a valve 23, 25 in. Look at the survival. In 5 years, drop compared general population. So we put the valve in without enlarge it. We decrease long-term survival of all this patient. What happens, we put a 29 in. This is the only group, men with the size 29 valve, their survival match the general population. We do not need to do a complex Ross to move patient survival to general population. We just need to put a large valve, improve the orifice. It makes sense, right? 29 valve has an opening of 23. They really match the general population. Look at survival 10 years. This is from data from 2007 to 2018. This is the only group can match the general population. So since we started this procedure, and in 2020, majority of all patients, about more than 75% patients, had valve size 29, 20% 27, and 5% 25. We do not put the small valve in anymore. And look at the hemodynamics. This compared to TAVR, significantly better than TAVR. Dr. David, I learned from him, is follow your patients. You do a David procedure, follow them, valve repair, follow them. I did annular enlargement. I follow all of them. I have done 196 patients. I follow all of them annually. The hemodynamics much better than TAVR, much better than probably published in any literature results. So the next will be the video. The full-length video is probably in annals. You can see the full-length. I'll play this video, how to do just a wide incision annular enlargement. It is really pretty simple. You cut the valve leaflets out, calcified. And you need to dissect the non-coronary cells a little bit like a David procedure and make a wide incision. Try to cut it really right underneath the aortic annulus to the left of the fibrous trigon. If you don't cut this far, you won't be able to upsize 3 to 4 valve sizes. Then to the nadir of right fibrous trigon here. Don't cut into the membranous septum. Then put a patch, it's about 4 centimeters wide. And this is a new modification, arc modification, which can preserve the native aortic mitral curtain, keep the shape of the basal ring and the flexibility. So from left of fibrous trigon to right of fibrous trigon, those are connective tissue. It's very, very, very strong tissue, can hold the stitches, not a problem. Just run it for proline, and at the tip, I buttress it. Then so to the right fibrous trigon here, just put the patch over the aortic mitral curtain to prevent bleeding. It is very important. It's very important to put the patch over the aortic mitral curtain here and make sure this suture line doesn't bleed, because if it bleeds, you have to reclamp and fix it. Then transition the nadir of the aortic annulus, sew it up along the aortic annulus all the way to the aortotomy. It's just one single suture for a proline, run it up. If you see any dark years, it's okay, just put an additional stitch, repair it. On the aortic annulus side, the suture line will be reinforced by your valve stitches, so it's not that critical, and secure it here. Left side, go from left of fibrous trigon, transition to the nadir of the aortic annulus, and sew it up to the aortic annulus. Try not to consume too much of the sinus tissue, because that will make the root smaller. Just sew it to the aortic annulus and secure it with the additional sutures. So you can root at least enlarge about 1/3. And you size it, make sure the nadir of the sizer touches 3 nadirs. Then put the valve stitches in, just like you're routinely doing it, without plaget. And Dr. Miller told me never use plaget, so I don't use plaget. So at the nadir of the non-coronary sinus, the transitional stitch, just one needle goes through the native tissue. Not yet. I'll show you when it gets there. So that's before. Next one will be nadir stitch. One through the native tissue and one through the annulus sewn to the patch. This is a vertical stitch. You actually have to come up along the aortic annulus because it's the aortic valve replacement. And the patch is very simple, just inside out and back in, because there's no plagets. Most time just four stitches. Then this side is the same, like any routine the AVR. You can run to, you can do whatever you normally do. It's not a problem. So this is nadir stitch. We'll secure the corner again of the left side. Then the vertical stitch coming up, you have to make this vertical stitch. The common pitfall mistake is go to the patch too early. Along the aortic annulus, which is sewn to the patch, just come up and across it. So when you see the valve, make sure one strut facing the left or right curvature, then two corner RCL will be on each side equally, won't be obstructed. And tie down, tie the native non-coronary sinus first and then native left coronary sinus, because those are the deepest. Then just tie it like you normally tie. Because the root enlarges so much, it's very easy to tie. The coronary is way above the struts. This is when the ascending aorta is small, you do a roof technique, you enlarge the ascending aorta to close the aortotomy to match it. So you trim the patch in triangular shape, insert the patch into the longitudinal aortotomy posteriorly, just for approaching run it. It actually makes the reclosure, it's very anteriorly very relaxed, no tension at all on the aorta. My fellow's doing it, I'm on the other side, so you have two surgeons. You can go from the apex, both sides come up. And you do one side, your fellow doing the other side, and just so it's close to the aorta. Really no tension on the aortotomy at all, and the hemostasis is good. Sometimes the apex can bleed, you put extra stitches there. So, yeah, also put a patch inside the aorta, cover the endothelium. So you can see anteriorly, there's no stress at all. It's just closed normally. It's really easy to teach, easy to learn, and it's reproducible. Oh, go back one second. Another slide. So when you do a AV valve for our patients, don't put a small dot 21, 23, 19. Put the largest valve in. Make sure safely create a space for TAVR and or down the road, or give patient best hemodynamics. Thank you.
Great. Thank you so much, Bo. Great video. Thanks. Thanks very much. Come have a seat. We'll